We're pleased to have two speakers for you today. Our first presenter is Carmela Gupta, who joined the American Immunization Registry Association as Senior Program Manager in September 2014. Prior to the role, Carmela worked for the Idaho Immunization Program for 5 years, first as the School and Child Care Immunization Coordinator, and later as the Immunization Outreach Communication Manager. Carmela has experience with immunization policy, outreach and communication, conference planning, and immunization information system forecasting. Today, Carmela will give an overview of immunization information systems, their use, and past successes. I will introduce our second speaker, Jana Pastier, who is the North Dakota Comprehensive Cancer Control Program Director, later. Without further ado, Carmela, the floor is yours.
My name is Carmela Gupta, and I'm the Senior Program Manager with ERA, and I'm excited to be here today discussing this topic with you. So today's learning objectives are define immunization information systems, describe the need for HPV vaccination uptake, and identify ways healthcare providers can be supported to implement reminder recall through IIS. Are you all still able to hear me? Something just, there we go.
Yes.
So there was an error. Perfect. Okay. So what are immunization information systems?
You know those are.
Yeah, I don't know. All right.
The folks who are giggling in the background, if you wouldn't mind muting your microphones. Thanks so much.
Right. So also known as immunization registries, immunization information systems are basically computer systems or public health databases that have information on vaccines that have been given to an individual. And so as you'll see here, they're confidential, population-based, and they're able to identify pockets of need and exchange data with multiple providers. They can assist schools and child care providers if they have immunization requirements, and they can also help improve vaccination rates and reduce vaccine preventable disease. So at the point of clinical care, an IIS can really provide healthcare providers with a consolidated immunization record to enable them to determine which vaccines their patient needs. And then at the population level, an IIS provides aggregate data on vaccination for use in surveillance and program operations. The data can help identify under-immunized communities, and with the goal being of improving vaccination rates and reducing vaccine preventable disease. You may be wondering, where are IIS located? We have them in every state in the United States. New Hampshire actually just had a law change this spring, and so they're the last state in the U.S. to have an immunization registry, but they are going to be on board here soon. And then you'll see on this map some circles, and those depict the jurisdictions that also have an immunization registry in addition to the state in which they're located. So what do IIS do? So overall, they create, they generate, and they assist. And what I mean by this is really IIS, they create consolidated immunization records. They pull from various sources, and folks can add data, and a provider can access that consolidated record at the point of care. And then next, they generate patient reminders, letting a patient know when a vaccine is due or maybe it's been missed. They can also generate population-based coverage data to help monitor immunization rates for a community. And then also, IIS can help with clinical decision support. And what we mean here is that it helps the provider determine when an immunization is due, and it helps ensure that children get only the vaccines that they need. And the immunization schedule is increasingly complicated, and so it is a really great resource for provider offices. And then finally, IIS can help immunization programs with vaccine management and inventory management. So how does data get into an IIS? Really, there are three main ways. That's through vital statistics, data exchange, and user interface. And vital statistics, really, that includes the birth and death records usually uploaded from a state health department. Data exchange is really the vast majority of data comes into an IIS through electronic health records. And that is linking to their system, like in a provider office or a pharmacy. actually 89% of pharmacies in 2014 had the ability to read and update a record in an IIS. And then finally, the third way is user interface, and this is becoming an ancient way of entering data into an IIS because this is really hand data entry. Somebody logs into the registry and it enters, vaccine by vaccine. So the provider sends the query to the IIS, then the IIS sends the patient history and forecast to the provider, letting them know which vaccine that patient needs. The provider then administers the vaccine and submits new information to the IIS. And then IIS updates that information and then spits out a new forecast to that provider. That's the cycle in which data gets into an IIS. This map here, it depicts the percentage of adolescents aged 11 through 17 that are participating in an immunization information system. And this data is from the 2014 ISA. And really, one thing to keep in mind as you look at this map is that VFC providers, so Vaccines for Children providers, are required now to submit immunization data to their IIS as a means of accountability. So they need to account for every vaccine dose that they are providing to VFC providers. So this is just something to note because as that requirement is in place for longer, the amount of data in a registry become more and more robust.
Carmela, I'm going to interrupt you really quickly for a second. Can everyone please mute their phones? We're hearing some plates clanging together in the background. Thank you so much.
Problem. Okay. So you might be wondering, if you have an EHR, why would you still need an IIS? And really there are a few reasons. So the first thing I'd like to mention is there are nearly, and we have more data from 2014, but there's nearly 2,500 certified EHR products. And so because it's kind of such a fragmented system, think of it this way, that data could be living in any of those systems, and it's not located in a consolidated location. Second here is that certified EHR criteria don't include all vaccines for children requirements. So the vaccine information sheet dates, that's an important piece that must be captured, and that is not something that is required in EHR. Also, kind of like I mentioned with the fragmented system, if a patient sees multiple providers and they're all using different EHRs, each EHR only has part of that picture. They don't have the patient's entire record readily accessible. And then finally, IIS can implement a rigorous algorithm for clinical decision support, and that's based off of ACIP recommendations. And they're able to leverage that, that forecasting algorithm into a consolidated record. That way the provider can make sure that they have all the information at their fingertips when they're making the decision of which vaccines their patient needs. So here, let's go ahead and consider a college student. So this college student is getting the HPV vaccine series. They go ahead and they receive their first dose at a college health center. Then they go in and they get their second dose, a month or two later at a pharmacy with a different system. And then 6 months later or so, they're home over Christmas break and they visit their family doctor and they get that third dose of HPV series, and we're thrilled that they've completed that series. But what's important to note is that if that third doctor, the one that they're visiting over Christmas break, doesn't realize that they've received their first or second dose, at the college health center or at the pharmacy, they may think that they're giving the first or second dose. So it is really important, especially with increasingly mobile populations, that we have all records in a consolidated location. And that's where an IIS would come in and make sure that this record was in one place so that that provider could make a decision, and also not give that vaccine too early, because as you know, HPV vaccine is an expensive vaccine, and if it's given too early, then it's considered invalid and would have to be repeated. So it's just another reason why it's so important that it be given
You have been muted. Your microphone has been turned on.
Okay, I'm muted for a second. Hopefully you can all hear me again. So we're now going to discuss trends and needs for HPV vaccination uptake. So the Healthy People 2020 objective for HPV 3-dose vaccination completion is 80%. And so that rolled out over 7 years ago, and as of now, only 4% of U.S. females and 22% of males between the ages of 13 and 17 have completed the 3-dose series. So this right here depicts the disparity between the meningococcal and Tdap vaccine and the coverage of HPV vaccines in females and males. And so you'll see here, meningococcal, we're at just under 80% coverage for adolescents aged 13 to 17. We're at 87.6% for Tdap, which is great. But then we're really lagging behind with HPV. So you see here 60% of females have received 1 or more doses, and 41.7% of males have. So those red arrows right there, that's really showing you that gap of missed opportunity. So these rates should be at least as high as the lowest denominator, which is meningococcal vaccine. So meaning that at the time that an adolescent is going into their healthcare provider's office and receiving the meningococcal and Tdap vaccines, which are required for middle school in many states across this country, they're not also receiving their HPV vaccine or initiating that series. And so this would be considered a missed opportunity. That's something that we would hope to be able to close that gap also using IIS. Here's some maps in case you're curious about our rates on a map. You see here that there really is a wide range in coverage. And this again is that 4 out of 10 girls are unvaccinated with HPV vaccine in this country. And as you see here, the state coverage really ranges. So there's at least 1 dose received at 38.3% in Kansas, and it goes up to 76% in Rhode Island. This map, you're able to see the rates of boys and their HPV rates. And the range here, it's a large range also. It's 23.2% in Indiana, all the way up to 69% in Rhode Island. So we'll discuss how healthcare providers can be supported to implement reminder recall through IIS. So what can you do? There are several things you can do. One would be to partner with your local or state immunization program. And in doing so, you can find out how your IIS operates. So each IIS in every state or jurisdiction are different. I mean, of course, there are similarities and some, base functionality amongst all of them. So they'd be the same. But you'd want to find out in your state or your jurisdiction, is it the IIS that sends reminder recall out to patients, or is it the providers that send these reminders? Also, another opportunity is educating OBGYNs. They may not know the benefits of IIS or the fact that they're able to use these systems for free. And another thing is just really ensuring that there is a place for IIS in a provider's workflow, and maybe adopting a no missed opportunity approach to ensure that patients receive the vaccines regardless of the primary reason for their visit. They can implement standing orders so that nurses may administer follow-up doses and establish walk-in appointments for follow-up doses to encourage series completion. So all these things would encourage increased coverage rates. Another thing is find out if linkages between your IIS and cancer registry exist. In the case of HPV vaccines, linkages amongst IIS and screening or cancer registries would enable study of the impact of HPV vaccination, including differences in rates of HPV-associated precancers and cancers, and the difference between vaccinated and unvaccinated populations. And then you could also consider pilot projects to target recalls for 3-dose completion or HPV initiation. And this is just a few ideas about ways to support healthcare providers. If you have any questions or you want to follow up with me directly, feel free to reach out. And my contact information is on the screen, and I would welcome your emails or phone calls. Thank you again for having me present today.
Thank you, Carmela, for your presentation. We really appreciate it, and I know some folks were having a little bit of trouble hearing, but we're happy to record your questions now. So if anyone has questions for Carmela, please type them in the Q&A pod, and we will go through them at the end of the webinar. But now I would like to introduce our second speaker, Jana Papier, who's the North Dakota Comprehensive Cancer Control Program Director. She graduated with her Master of Public Health from Benedictine University in 2012. She began her career as a Vaccines for Children coordinator for North Dakota and took a special interest in HPV prevention. Jana crossed over to the cancer programs through her role as the immunization liaison for the North Dakota Cancer Coalition HPV Task Force. Jana co-facilitates the HPV Task Force with the North Dakota Immunization Program. Today, Jana will provide insight into the real-world application of Immunization Information Systems. Thank you, Jana. And since we had some folks that had trouble hearing Carmela, if you could please make sure to speak up, that would be appreciated. Thank you.
Will do. Thank you so much. Hopefully you can hear me.
Yes.
Okay, good. Thank you for introducing me. Like she just said, I am the Director for Comprehensive Cancer Control in North Dakota, and I have been doing this for 2 years and was with immunizations years before that. But my own personal mission for HPV prevention began many years ago, and I'm just really happy that I've been able to parlay my personal passion into my professional work. So I'm very lucky. So today, I'm hoping to just give kind of an aerial view, the understanding of the background of our personal IIS system here in North Dakota, how we use it to increase vaccine uptake, specifically HPV, and then just review a couple of our successful implementation at local level projects that we've been doing for the past several years as well. So a little background on our immunization information system is that, like Carmela said, it's a confidential population-based system. It's computerized, and for us, it collects all vaccination data for North Dakotans. We consider it a lifespan system, which includes infants, children, adolescents, and adults. And although adult doses are not mandatory to be entered into our registry, we do have 89% of all adults in North Dakota entered in there, which is, to us, really great. It started out as a modem dial-up system, so if you can imagine what that must have been like, and was originally built with Blue Cross Blue Shield through contracts that we have with them, and was updated to a web-based system in 1996. And then for us, the NDIS is still hosted and supported by what's now known as Noridian Mutual Insurance. So it's a partnership between the immunization program and a vendor that we have ours developed. And then in May 2013, we did this huge overhaul and went through a big upgrade, moving to a .NET technology, which that's just some technical jargon that that registry people know. But a little additional step for North Dakota, Century Code does require that North Dakota providers enter all childhood immunizations to the registry within 4 weeks of administration. Thanks to interoperability with a lot of EHRs, that's actually more instantaneous at this point. And we do have, our rate is 95% of immunization data is entered within that 1 month, and that 73% of those doses are actually within 24 hours. For our registry, we have more than 1.2 million active client records for North Dakota and more than 11.5 million doses that are recorded in our registry this time. So you heard Carmela mention the registries. The North Dakota is one of 6 CDC Sentinel sites, which means we receive additional grant funding to be able to develop our IIS even further. And we've consistently met these 3 criteria. At least 85% of vaccine provider sites are enrolled in our IIS. At least 85% of the children less than 19 years old are participating in it. And 70% of the doses administered from the Sentinel site area are submitted and processed to IIS within 30 days. So we consistently have high quality data available. We have over 218 providers that are connected through the Health Information Network in North Dakota, and that's that bridge between EHRs and the registry. And that helps eliminate double data entry for health systems and the workers. And these providers, the 218, they represent more than 60% of all the immunizations that get reported to the NDIIS. So in 2006, we implemented the ability to change a client status, which is really helpful in monitoring our rates and making sure they're accurate. We call it a MOGI, which stands for moved on elsewhere, or lost to follow-up. And so we have 26,243 clients that are currently marked as MOGIs. And to mark somebody as a MOGI, it means that you've attempted to contact them 3 times unsuccessfully, and it removes them from the provider that they were last seen at. So that means that person that's not coming in for immunizations but is due for immunizations won't be counted against that specific provider's rates when they get their reports from the VFC AFIX programs. And we currently have just over 5,000 clients that are marked as lost to follow-up. So these could be people that moved out of state. It could be people that just moved away from that provider. But once they're seen at a new physician and get immunizations there, they automatically get associated to that provider's number. Another point, a North Dakota information system has forecasting capability, and that data is electronically sent to the EHR for all of our interoperable providers. The forecaster marks doses as invalid if they don't meet the approved immunization schedule rules that are set by ACIP. So that means it'll forecast for a dose that is within the valid time frame. So it just helps us maintain not only the quality, but the effectiveness of the vaccines that we're giving. We also have manual client-level deduplication, and that was implemented in 2007, and then electronic deduplication was implemented in 2009. And then it went to automated client level in 2016, which we are really excited about, because when you implement that interoperability between EHRs and the IIS system, you can sometimes get 2 clients or even 3, if not all of their demographic information is exactly the same. So this is an automated way to merge records, and that just reduces the amount of time that people are going into immunizations, and also teaching local providers that don't immunize how to use the reminder system and refer them to the local public health unit. And then also developing education and displays for their local migrant health clinic, because this particular community has a high population of Hispanic people, which the rest of the state may not. And in that 1 year, they were able to increase their immunization rates by 10.6% for their adolescents, which is fantastic. And they have actually become the model project for our other local public health units moving forward. So then in 2014, local public health unit, that first one continued, and we actually funded a second. This time they got $7,000, and they increased from 23.8% to 41.9% HPV completion rate for their adolescents, just using the in-school immunization clinic format and then doing the client reminders. They evaluated how they were doing the reminders between letters, postcards, and phone calls, and this particular group found that phone calls definitely had a higher impact, but it's going to be different from each community, so we do encourage all of our subcontract grantees to make sure that they're evaluating the methods that they're communicating with their community members. So that second local public health unit, they received $7,000 as well, and they replicated the first project, and they were able to increase their immunization rate for HPV by 10% in that first year. So we kind of see that as a consistent number. They also implemented MOUs with the schools that had the schools agree to provide time and space for them to be able to provide immunizations on site 3 times each year. And then in 2015, we actually kind of had a banner year for projects. We were able to leverage additional funding of $28,000 from the immunization program, and so we were able to provide 6 subcontracts at $7,000. The first one continued and went into development of policy and systems to make it sustainable. The second one revised their contact methods because they thought the first year didn't go so well, although we did find that 10% increase is quite significant. We also had a region of public health units that implemented school-based clinics in 7 counties, and then an additional local public health unit that also began school-based immunization clinics. So we do continue funding projects as long as they're still growing. The first 2 have since made their projects sustainable, and so we're very excited about that. We do work with the immunization program specifically to provide oversight on those to make sure that the strategies that they're implementing work and that they aren't somehow duplicating the services that the immunization program does, because they also do a statewide reminder recall in North Dakota, and they use the NDIIS to determine who is coming due or past due for any of the doses of HPV and send reminders. So this is where the immunization registry is essential. So this past year, we also had the opportunity to work with 2 branches of our largest health system in North Dakota, and they operate in different regions of the state, one on the east side and one in the central area. They each received $7,000 from our subcontract project. They also received each $50,000 from the immunization program from a separate grant. And what they did was develop policies and processes for the reminder recalls of their own patients, provided community education and a free screening of the film Someone to Love, and had panelists that answered questions at the end and shared their own experiences, because it included, I'm sorry, I don't know what's happening there. It included, survivors that shared their stories, a male and female. They had about 100 people from the community that came and watched that free screening, and the producer of the film also attended. So it was a really great opportunity, and then the central area replicated that screening 1 month later and had that happen here in Bismarck, North Dakota, where they actually had more providers, nurses, physicians that were in attendance. And I think both audiences really took away a lot from that. And the other thing that this health system did is they developed a report in their EMRs that allows them to assess the immunization rates per physician. So when we say the registry can do provider level, we're talking about a provider clinic or hospital system that operates under one number in the registry. The EMRs for this particular health system, they developed a back-end report that can actually do it by physician, and then they posted those rates in a ranking order publicly at their clinics so that people could see where physicians were in their immunization rates for HPV. And so that generates a little bit of competition because no physician really wants to be at the bottom of that. And it also helps people know what doctor they can go to, even as a peer, to get a little more information about the vaccine if they're hesitant for some reason, because vaccine hesitancy does not escape physicians. And so this year we're going to be funding 3 projects, and they will be doing school-based immunizations, and we have 2 new counties that are going to be involved, so we're very excited about this. It's clearly a successful model. And so I did mention that we do joint oversight between myself and the immunization program manager. We have a very strong emphasis on that system change and policy development to make it sustainable. And we give priority to applicants that are addressing those underserved rural communities or disparate populations when we're selecting our grantees. And the real thing that I want to help people take away is that this is not kind of a one group issue. We partner and we include engagement across all sectors to ensure that our messaging, education, and priorities are all the same and being addressed the same way without duplicating each other's efforts, but complementing them instead. So major decisions about HPV projects and implementing strategies, they're never made by one entity alone. We try to coordinate our activities as much as possible with all of the groups that you see on your screen here. Oral health and family planning have been great. They help us get into some kind of non-traditional places and work with people we may not have had contact with because maybe family planning doesn't think to talk to the cancer staff, or oral health doesn't talk to immunizations. So it just helps us cross those sectors and make sure that all of our priorities are getting addressed. And then we did do a survey. I highly recommend doing this if you have a chance, and I'm just going to touch on this briefly because we didn't necessarily find out anything that was groundbreaking from this survey, but what we did is find out that what we thought was really correct overall, and that perception from providers and parents is really important. And so the people that identified as RNs or other young medical professionals are more likely to make a very strong recommendation. And then for parents, the older cohort, or those that don't have religious affiliations, are more likely to immunize their children specifically for HPV. So again, that wasn't really unexpected results, but still very important. And then things that we are using for our priority setting is that the concerns, number 1 is vaccine safety. Number 2 is that the providers are not addressing the vaccine as being necessary. So we're working a lot with providers about how to talk to your patient. And so then we are just planning ahead. We did do our convening of the roundtable on August 5th. We'll be doing ongoing training and assistance, implementing reminder system processes across the state. And we will be encouraging and assisting in the facilitation of screenings of the film Someone to Love, especially using a panelist. And this is just the brochure that we had made to hand out. The 2 events that we did with this film as part of our subcontract project were amazing, and we challenge anybody to watch this film and not have some sort of reaction to it. Myself and the immunization program manager are working specifically with one of our larger health systems to pay for the screenings for anybody in a community served by that health system, including partner health systems that might just be in that community as well, to provide this screening for their staff, for their patients, or for their communities. And so if you have a chance to see this film, we highly recommend it. And I just wanted to do an acknowledgement of our immunization program, the manager, Molly Howell, and then our NDIIS manager, Mary Wanarovich. And Mary is a wealth of knowledge when it comes to how we can utilize our NDIIS, and she's always coming up with great ideas on how we can improve it. So you can contact me if you have any questions about how to do subcontract projects or how we've implemented them, anything like that. Thank you so much for letting me talk today about it. Obviously, I'm very proud of what they've done here. So thank you so much.
Thank you, Jana. That was a really great pair of presentations. We have a ton of questions that have come in. So I wanted to just address the first. I'm going to punt it to Carmela. If you could address Cheryl from South Carolina's questions, if you could talk a little bit more about the cost of using IIS and some of the sort of caveats that South Carolina might want to be aware of.
Yes, hi Cheryl. Thanks for that question. So in terms of a cost of using the IIS from the perspective of a healthcare provider, there is no cost. So I wasn't sure if you were actually asking, because the way it was worded, it says there may not realize that IIS is available. Well, the cost of using a system, or what is the cost of using a system of this nature? So I do see that South Carolina was a homegrown IIS, meaning that they didn't go through a vendor, but they actually developed that on their own. But if you have follow-up questions about that, feel free to reach out to me.
Okay, we've had a couple of questions come in about the plan, or is there a way to integrate different state IISs that could help providers see an even more comprehensive picture? And then a second person asked, patients sometimes receive vaccines in multiple states. What is the likelihood that IIS will be able to communicate across state lines? Carmela, do you want to take a stab at that? Or Jana, if you've had direct experience, I know you mentioned it as a challenge a couple times in your talk.
So this is Carmela. I can start off answering that, and then Jana, if you want to chime in, go ahead. But just to answer that, it's really not a technical issue. It's more of a policy issue, the whole exchanging data across state lines. And so IIS have the ability to do that, but oftentimes the legislation within a state prohibits the sharing of data across those state lines. So we absolutely know that that is something that is important, especially for cities that are right on a state border. And so what you all could do is help advocate for changes to policy. Jana, do you have anything to add?
Yeah, just from our experience here in North Dakota, we do have a lot of those cities that border the east side, which would be Minnesota. And so a lot of patients that kind of go back and forth right there. And so certain immunization program staff have been granted read-only access to other registries, but the registry here does not actually communicate directly, and it's because of that policy that Carmela brought up, that a lot of it has to do with legislation and that privacy of health information.
Speaking of privacy, we had someone ask a question that patients and some providers are concerned about confidentiality of their records in IIS, and how can we assure them that the records are secure?
So this is Carmela. I can answer that. Basically, IIS users must be authorized to have access to the data that's stored in an IIS. Just any person off the street can't get the same access level that a healthcare provider can get to view all records within that IIS. The users must sign an agreement, and they have to follow strict confidentiality and security policies. And so that protection of IIS data is actually managed through state privacy, confidentiality, and security laws. And so those are the federal privacy rules and regulations. And when information is disclosed improperly, there are penalties for doing that. And so all that is really specified, and so hopefully that would assure providers and patients that the data within the registry is secure.
We have a couple of technical questions that hopefully either of you could address. Is there a hierarchy of HPV vaccinations for the systems to use, so for the 2, 4, and 9 for the different shots?
This is Jana. I'll take that one. Well, so there isn't. Providers, it's really just whatever immunization you have on hand. I know in North Dakota, the 2 has been available to order, but nobody has ever actually used it because the 4 was available too. And we're actually almost at 100% HPV-9 at this point. But as of the end of this year, when we go into 2017, only HPV-9 is going to be available.
Okay, that's helpful. And do you think the systems will update quickly if and when the 2-shot series is recommended?
So this might be more of a Carmela question from the background point, but I do know that as North Dakota becomes aware, and we do have people that sit with the ACIP and the AHEC organizations, but when we become aware that something like this might be happening, the algorithms are already getting written to be prepared for implementation as soon as those recommendations go into effect. So, I mean, for us, anytime there's been a change in schedules or like when meningococcal B got introduced, those were all put into the registry immediately.
And I would echo that. I mean, it is different in every state, and it sounds like North Dakota is really preemptive in anticipating those things. While it's not immediate, we do know that all IAS do work to get their systems updated as quickly as possible, following any changes to ACIP recommendations. So.
Okay, one more technical question. For deduplication in North Dakota, what fields are used to determine merging records? Birth date, social security number, etc.
That is a great question. It's a combination. It's usually what happens is a lot of times you'll get a record that doesn't have a middle initial that comes through an EMR, but the middle initial is available in the registry, and so that might be the indicator there where everything else might be the same. But it does go through a human review. It sets up an automated report of all the deduplication records that are waiting to be approved. But things like social security numbers, if those are available, we always encourage people to make sure that those are in the registry and also in their EMRs. Birthdays, last names, those are all things that are not considered a big part of that would be the address. Because people do move around a lot, but it is something that is looked at as part of that manual review.
Great, thank you so much. We've got some more sort of resource and content questions coming up now. Are either of you aware of any type of information sheet available that could be shared with OBGYNs? Something off the shelf?
I know that a lot of the local state level cancer coalitions do develop fact sheets like that, and I know that our HPV task force has been working on that as well. It would be the same information that we would give any other physician. If you're seeing someone that's of age, before the age of 26 and over the age of 9 for services who hasn't been vaccinated and is not pregnant currently, we would recommend that vaccine. So it's the same recommendations across fields for doctors.
Okay, thank you. A commenter said, in Massachusetts, pharmacies have had great success in covering patients for recommended vaccines using the state's IIS. Is anyone aware of any work being done, or have you considered utilizing pharmacies nationwide to provide the HPV vaccine?
Jana again. Sorry, Carmela. I think I'm taking a lot.
Go for it. That's great.
The use of pharmacies with vaccine administration is a policy, usually at a legislative policy at state level. So it really depends on what authority the state has granted those particular pharmacies. I know that we are in the talks of how can we start utilizing our pharmacies better with HPV immunization.
And this is Aubrey at GW. I know that this is also a topic of interest and a work group focus for the National HPV Roundtable, so I would keep an eye on this as something that could increase across the country in the next few years. Another question came in. Do you have any advice on how a state could leverage the IIS to develop provider-level feedback reports? Something that could be leveraged at a clinical level for quality improvement?
So this is Carmela, and if I'm understanding your question correctly, that's actually happening, and it's called AFIX. So AFIX is a quality improvement program used by IIS awardees and VSD awardees to raise immunization coverage levels. They also are aiming to reduce missed opportunities to vaccinate and improve standards of practice at the provider level. And so part of that, A stands for assessment, then F is feedback, I is incentives, and E is exchange. So they assess the healthcare provider's vaccination coverage levels and immunization practices, and then they provide feedback as a report that shows them basically how they're doing and what their coverage levels look like within that practice, and then they work with them to recognize and reward improved performance, and there's an exchange of information with providers to follow up on their progress toward quality improvement in immunization services. So feel free to type in a follow-up question if that doesn't answer it, but I do believe that IIS are currently being leveraged to help providers improve their rates using that level of overview.
All right, and in our last minute here, one final question. What were some of the hardest lessons learned when implementing and working with IIS from a comp cancer control professional's perspective?
Well, okay. I feel like I might not be able to answer this fairly simply because I started in the VFC, that Vaccines for Children AFIX program with the immunization program. I do feel that having that background and understanding that that is a tool and a resource for us to use has certainly helped me when it comes to helping our grantees who are using the registry, and that's where they're getting their data. It definitely helped me bridge that gap there, having the knowledge and then having a relationship with our NDIIS coordinator. It's really important to use that person because they can pull reports for you usually at the drop of a hat, really, and tell you what's going on in different counties, different providers, statewide, for every single vaccine that's available in your state. And so I think it's more just about knowing the person to contact and having that information. If you're going to do work with people on local implementation, it's really important to understand what their rates are and how they're calculated.
Great.
I hope that helps.
Yeah, thank you so much. Any final comments that either of you want to share before we sign off? We are at the top of the hour, and we have some questions here that we weren't able to get to, but I would encourage everyone to look at the links at the top of the pod. There is an archived webinar as well as a social media toolkit for communicating with clinicians about dispelling some of those myths around HPV vaccination. And, there are lots of resources out there on the research and effectiveness of the vaccine, which we got some questions about. Any final comments from our speakers?
This is Jana. I just want to thank you all and just say, by all means, email me if you have questions or call me about the subcontract projects, about funding, leveraging across sectors. I'm an open book, so by all means, contact me if you would like.
And this is Carmela. I'd just say the same. Feel free to reach out if you have any questions, and thank you again for including me on today's webinar.
Great. Thank you so much. While I wrap up quickly with some closing remarks, please take a few moments to complete the session evaluation polls that popped up on your screen. We really do take feedback seriously and incorporate your suggestions to continuously improve our events. I'd like to extend a huge thank you to our experts, Carmela and Jana, for their fantastic presentations and the discussion. Thanks all to everyone who participated and submitted questions. They were really good questions. I hope that you found the meeting informative. We encourage you to stay in touch and continue this conversation as you prepare to introduce strategies using IIS to increase HPV vaccination in your area. We know that HPV-associated cancers can be prevented, and we've heard compelling arguments today about how IIS is integral to realizing HPV vaccination coverage. Please check out our Comprehensive Cancer Control Technical Assistance website at www.cancercontroltap.org to access more resources and professional development opportunities. Thank you again to everyone and to National AHEC Organization for co-hosting with us. We hope to see you again soon.